So the first specimen is a thyroid aspiration specimen. On low power, we don't see colloids. The cellularity is pretty scant. So we have very low cellularity specimen. However, if you go to high power, and these follicular cell indeed demonstrate some nuclear feature of PTC, which include the powdery ground glass type of chromatin pattern. The shape of the nucleus is a little bit elongated. There are some focal overlapping. The contour for the nuclear is relatively irregular, and we do see quite frequent grooves within these cells. So each cell looks a little bit like a coffee beans. So based on this morphology, the cells are highly suspicious to be papillary thyroid carcinoma. So we only have a few cluster of cells. So again, these also demonstrate features of papillary thyroid carcinoma. We only have a few cells. We do not identify any pseudo inclusions, and the sonographic finding was equivocal. It actually looks more like it's a very large nodule, and with a very non-specific sonographic feature. Occasionally, it can also be PTC, but because the sonographic finding is also not highly suggested, so I think for this specimen, we will make diagnosis of TBS5 suspicious for papillary thyroid carcinoma. So usually for the suspicious category, it would most commonly apply to the paucicellular specimen that we don't have enough diagnostic material to call, or we do have a hypercellular specimen, but the degree of nuclear atypia is like equivocal. It's more like a subtle side. Occasionally for a non-BRAF, papillary thyroid carcinoma can also present in this way. So for this case, we will call this suspicious for suspicious for papillary thyroid carcinoma. So the next specimen is a EUS guided aspiration specimen targeted the pancreas. In the liquid-based cytology, we don't have a lot of material. So this is the direct smear. So in the direct smear, we realize for the EUS guided biopsy, it is very common. On the slides, we will see some normal component along with the aspiration tract from the inside the intestine. So here we see this is intestinal type mucosa with nice honeycombing arrangement, and the cell seems to have some like missing cap, and the cell have a very regular honeycombing pattern. So in contrast to this, here we have some more atypical cells. So you can appreciate that the chromatin pattern is already abnormal, and it arranged in an irregular abortive type of glandular pattern, some overlapping. The nuclear size is variation, and the shape and the contour is also variable. So this looks very much like an adenocarcinoma. So in some occasion, if it is a well-differentiated adenocarcinoma, you will still maintain a relatively regular arrangement, but the nuclear is slightly a little bit atypical. There is no prominent polymorphism. So these make the diagnosis sometimes more difficult. So I think for this case, we do have a lot of areas suspicious for the well-differentiated adenocarcinoma, such as this one. So again, we can appreciate that this is what we call the drunken honeycombing, which means that the distance between the nuclei is a little bit uneven. Some is more tight, some is more distant. Some of the cells have small but distinct nucleoli, and the long axial of many of these cells seems to be like crossing with each other, but we don't have very striking polymorphism. So we will usually need to go to find somewhere more definite, such as like this focus. So here we have a definite 4:1. So we have big difference in the size within the same cluster. And here we have a tightly overlapping glandular cell with very irregular arrangement, and most of the cells do have prominent nucleoli. So I think these two focus is more diagnostic for adenocarcinoma, and this focus is highly suspicious for adenocarcinoma, but for the definite diagnosis, it's a little bit difficult. So in this specimen, we have a lot of these like equivocal area, so suggesting that the majority of the component is likely a well-differentiated adenocarcinoma, such as this one. Again, on low power, it seems to be still maintain the honeycombing type of feature, but just you can find a eruptive individual cell looks more polymorphic and with like a variation of the size of the nucleus over here. So these clusters also highly suspicious for adenocarcinoma, but well differentiated. So among these well differentiated area, we just need to identify the area that we can make more confident malignant diagnosis, which include what I say 4:1 is very important, and prominent nucleoli is also very important. So for this case, we will call positive for adenocarcinoma. And additionally, usually I will check for the serine tumor markers such as CA199 and the image finding to see if those are matching for pancreatic cancer. So then we have two bone aspiration specimens. Both are from relatively elder male. And for the first patient, he had a history of lung adenocarcinoma and prostatic adenocarcinoma. So for these type of specimen, we realize that they have metastatic epithelial cells arranged in a glandular pattern. So for the glandular arrangement with more like a small type of rosette, this is more common that we will see in the prostatic cancer. For this particular case, the nuclear atypia is a little bit more severe than the usual type of relatively uniform morphology of a prostatic cancer. However, because of this small like acinar type of growth pattern, this is more likely to be a pancreatic origin than the primary lung origin. Usually for the primary lung, we will see a bigger cluster, larger cluster of the glandular cell. So these smaller rosette, almost like microfollicular pattern, is more consistent with the prostatic cancer. So the next specimen is also suspicious for pancreatic cancer from a 72-year-old male. So this specimen is also a little bit unusual. First of all, for the pancreatic cancer, unless it is under treatment, it's relatively uncommon to see the background necrosis. So we have some background material, and we have some pretty tight cluster of cells, And additionally, there is also one feature uncommon is that they have some signaling type of cellular morphology, which is kind of uncommon here again. Another signaling cells. So despite the patient with the past history of a prostatic cancer, the overall morphology pattern is a little bit unusual for prostatic cancer. So I think these need to be checked for immunohistochemistry with the concurrent biopsy specimen. So if this is the only type of specimen, I think this is compatible with prostate, but the background necrosis is a little bit too much, and we do identify occasional cells with signaling type of morphology, which is relatively unusual. So these need to be confirmed. But the patient do have elevated PSA level, so it's still likely to be a prostatic cancer. We will send these out as positive metastatic adenocarcinoma, and the biopsy can check for the immunohistochemistry. So finally, this is the pap smear. So on low power, we can tell that the pap smear looks quite dirty. We don't see a lot of superficial intermediate squamous cell. Instead, we have a lot of inflammatory cells. So the epithelial component is relatively scant, and along with some background, like could be the degenerative blood material, and with some dirty type of debris similar to the necrosis. So along this specimen, so then we have these some very tight cluster of cells. Additionally, these squamous cells seems to be also a little bit abnormal. So I think this is qualified for ascus. But the problem is that these tight, very tight, like a hyperchromatic cluster, so it's a hyperchromatic crowded group. It does has peripheral like arrangement, suggesting that it is more like a glandular cell. So these looks like a degenerative glandular cells with hyperchromasia and a crowded arrangement. And here we have a more well-preserved glandular cells. So at the luminal border, you can appreciate that it seems to have some mucinous, like a apical arrangement. So these well-preserved focus is more likely to be the endocervical cell. So we have a typical endocervical cell which is very tightly arranged and also hyperchromatic. So right next to it, so we can appreciate these, despite this is relatively indistinct, but now you can tell that this cell looks atypical and with prominent nucleoli, and sort of like admits with the necrotic type of debris. So these guys is abnormal, and whenever the glandular cells present with nucleoli, you need to think about the possibility of invasive adenocarcinoma. So we checked the history. The patient had a past history of endocervical adenocarcinoma, and she received cone biopsy at the other hospital. And after that, she came to our hospital for further management. So you can tell that this is the degenerative blood. So you can tell that in this specimen, this is likely the patient still have invasive adenocarcinoma, along with some atypical squamous cells, but we do not see definite high CO cells here. And again, here is a typical glandular cluster. So for this type of specimen, because the patient has already received the treatment, and it can admix with a lot of reactive changes because of the cone biopsy, as well as that the tumor or the lesional cell might be a little bit scant. So it's kind of difficult to appreciate the prominent tumor diastasis pattern, as we will see in a like untreated primary adenocarcinoma of the endocervix. But here we do highlight these highly atypical glandular cells, and some of the cells also show prominent nucleoli along with the background sort of like a necrosis pattern. And here we do identify what we call as these are degenerated mucocytes. So this is similar to the ileocondyl type of urine background material, which is a suggestive sign for the endocervical mucinous adenocarcinoma with tumor diastasis. So here we have some evidence of tumor diastasis. So we will sign these out as adenocarcinoma, endocervical origin. Okay. But the lesional cell, I would say, is very, very scant in these specimens. Okay, that's for all the case today. Thank you.